Welcome to this video entitled Pancreatitis. Let's begin with a definition. 1. Acute pancreatitis, abbreviated as AP, is an inflammatory disorder of the pancreas characterized by severe pain in the upper abdomen and increased serum concentrations of pancreatic lipase and amylase. 2. Chronic pancreatitis, abbreviated as CP, is a syndrome of destructive and inflammatory conditions resulting from long-standing pancreatic injury. It is characterized by irreversible fibrosis and destruction of exocrine and endocrine tissue, but is not invariably progressive. We will now discuss acute pancreatitis. Let's begin with its pathophysiology. 1. Gallstones and alcohol abuse account for most cases in the United States. A cause cannot be identified in some patients. Idiopathic pancreatitis. 2. Many medications have been implicated, Table 28.1. But a causal association is difficult to confirm because ethical and practical considerations prevent re-challenge. 3. Acute pancreatitis is initiated by premature activation of pancreatic zymogens, i.e. inactive enzymes, within the acinar cells, pancreatic ischemia, or pancreatic duct obstruction. 4. Release of active pancreatic enzymes directly causes local or distant tissue damage. Trypsin digests cell membranes and leads to the activation of other pancreatic enzymes. Lipase damages fat cells, producing noxious substances that cause further pancreatic and peripancreatic injury. 5. Release of cytokines injures acinar cells and enhances the inflammatory response. Injured acinar cells liberate chemoattractants that attract neutrophils, macrophages, and other cells to the area of inflammation, and increased vascular permeability promotes tissue edema. 6. Pancreatic infection may result from increased intestinal permeability and translocation of colonic bacteria. 7. Local complications in severe acute pancreatitis may include acute fluid collection, pancreatic necrosis, abscess, pseudocyst formation, and pancreatic ascites. 8. Systemic complications may include cardiovascular, renal, pulmonary, metabolic, hemorrhagic, and CNS abnormalities. And now let's discuss the clinical presentation of acute pancreatitis. 1. The clinical presentation depends on the severity of the inflammatory process and whether damage is confined to the pancreas or involves contiguous organs. 2. The initial presentation ranges from moderate abdominal discomfort to excruciating pain, shock, and respiratory distress. Abdominal pain occurs in 95% of patients and is usually epigastric, often radiating to the upper quadrants or back. The onset is usually sudden and the intensity is often described as knife-like or boring. The pain usually reaches its maximum intensity within 30 minutes and may persist for hours or days. Nausea and vomiting occur in 85% of patients and usually follow the onset of pain. 3. Clinical signs associated with widespread pancreatic inflammation and necrosis include marked epigastric tenderness, abdominal distension, hypotension, and low-grade fever. In severe disease, bowel sounds are diminished or absent. Dyspnea and tachypnea are signs of acute respiratory complications. Pause the video and carefully scrutinize Table 28.1 summarizing medications associated with acute pancreatitis before advancing to the next slide. Let's now progress to the diagnosis of acute pancreatitis. 1. A definitive diagnosis of acute pancreatitis is made by surgical examination of the pancreas or pancreatic histology. In the absence of these procedures, The diagnosis depends on recognition of an etiologic factor, clinical signs and symptoms, abnormal laboratory tests, and imaging techniques that predict disease severity. 2. The serum amylase concentration usually rises 4 to 8 hours after symptom onset, peaks at 24 hours, and returns to normal over the next 8 to 14 days. Serum amylase concentrations greater than 3 times the upper limit of normal are highly suggestive of acute pancreatitis. 3. Serum lipase is specific to the pancreas, and concentrations are usually elevated. The increases persist longer than serum amylase elevations and can be detected after the amylase has returned to normal. 4. Acute pancreatitis may be associated with leukocytosis, hyperglycemia, hypoalbuminemia, mild hyperbilirubinemia, and elevations in serum alkaline phosphatase and hepatic transaminases. 5. Marked hypercalcemia indicates severe necrosis and is a poor prognostic sign. 6. Dehydration may lead to hemoconcentration with elevated hemoglobin, hematocrit, blood urea nitrogen, and serum creatinine. 7. C-reactive protein increases by 48 hours after the onset of symptoms and may be useful in distinguishing mild from severe pancreatitis. 8. Some patients with severe pancreatitis develop thrombocytopenia and a prolonged prothrombin time. 9. Contrast-enhanced computed tomography, abbreviated as CT, is used to identify the cause of pancreatitis and confirm the diagnosis. Magnetic resonance imaging is used to grade the severity of acute pancreatitis and identify bile duct abnormalities not seen on CT. Ultrasonography is useful to determine pancreatic enlargement and peripancreatic fluid collections. Let's now consider the desired outcome. Treatment of acute pancreatitis is aimed at relieving abdominal pain and nausea, replacing fluids, minimizing systemic complications, and preventing pancreatic necrosis and infection. We will now look at pharmacologic treatment of acute pancreatitis as shown in Figure 28.1. 1. Medications listed in Table 28.1 should be discontinued, if possible. 2. Initial treatment usually involves withholding food or liquids to minimize exocrine stimulation of the pancreas. 3. Nasogastric aspiration is beneficial in patients with profound pain, severe disease, paralytic ileus, and intractable vomiting. 4. Patients predicted to follow a severe course require treatment of any cardiovascular, respiratory, renal, and metabolic complications. Aggressive fluid resuscitation is essential to correct intravascular volume depletion and maintain blood pressure. IV colloids may be required because fluid losses are rich in protein. Drotrocogon alpha may benefit patients with pancreatitis and systemic inflammatory response syndrome. IV potassium, calcium, and magnesium are used to correct deficiency states. Insulin is used to treat hyperglycemia. Patients with necrotizing pancreatitis may require antibiotics and surgical intervention. 5. Nutritional support with enteral or parenteral nutrition should be initiated if it is anticipated that oral nutrition will be withheld for more than 1 week. 6. Analgesics are given to reduce abdominal pain. In the past, parenteral meperidine, dosed at 50 to 100 mg every 3 to 4 hours, was usually used because it causes less spasm of the sphincter of Oddi than other opioids. Meperidine is used less frequently today because it is not as effective as other opioids and is contraindicated in renal failure. Parenteral morphine is sometimes used, but it is thought to cause spasm of the sphincter of Oddi, increases in serum amylase and, rarely, pancreatitis. Hydromorphone may also be used because it has a longer half-life than meperidine. Patient-controlled analgesia should be considered in patients who require frequent opioid dosing, e.g., every 2 to 3 hours. 7. There is no evidence that inhibiting gastric acid secretion by anti-secretory drugs prevents exacerbations of abdominal pain, but they may be used to prevent stress-related mucosal bleeding. 8. Octreotide, 0.1 mg subcutaneously every 8 hours, may decrease sepsis, length of hospital stay, and perhaps mortality in patients with severe acute pancreatitis, but there are insufficient data to support its routine use in treating acute pancreatitis. 9. Only patients with severe acute pancreatitis complicated by necrosis should receive infection prophylaxis with broad-spectrum antibiotics. Agents that cover the range of enteric aerobic gram-negative bacilli and anaerobic organisms should be started within the first 48 hours and continued for 2 to 3 weeks. Imipenem C. Listatin, dosed at 500 mg every 8 hours, may be most effective. A fluoroquinolone, e.g., ciprofloxacin, or levofloxacin, with metronidazole should be considered for penicillin-allergic patients. Pause the video and carefully scrutinize Figure 28.1, which is an algorithm of guidelines for evaluation and treatment of acute pancreatitis before advancing to the next slide. Let's now switch gear to surgery. Removal of biliary tract gallstones with endoscopic retrograde cholangiopancreatography or surgery usually resolves acute pancreatitis and reduces the risk of recurrence. Surgery may be indicated in acute pancreatitis to treat pseudocyst, pancreatic abscess, and to drain the pancreatic bed if hemorrhagic or necrotic material is present. We will now discuss evaluation of therapeutic outcomes. 1. In patients with mild acute pancreatitis, pain control, fluid and electrolyte status, and nutrition should be assessed periodically depending on the degree of abdominal pain and fluid loss. 2. Patients with severe acute pancreatitis should be transferred to an intensive care unit for close monitoring of vital signs, fluid and electrolyte status, white blood cell count, blood glucose, lactate dehydrogenase, aspartate aminotransferase, serum albumin, hematocrit, blood urea nitrogen, serum creatinine, and international normalized ratio. Continuous hemodynamic and arterial blood gas monitoring is essential. Serum lipase, amylase, and bilirubin require less frequent monitoring. The patient should be monitored for signs of infection, relief of abdominal pain, and adequate nutritional status. We will now progress to chronic pancreatitis. Let's begin with its pathophysiology. 1. In most individuals, chronic pancreatitis is progressive and loss of pancreatic function is irreversible. Permanent destruction of pancreatic tissue usually leads to exocrine and endocrine insufficiency. 2. Prolonged ethanol consumption accounts for 70% of all cases in the United States. 10% result from other causes, and 20% are idiopathic. 3. Ethanol-induced pancreatitis appears to progress from inflammation to cellular necrosis, and fibrosis occurs over time. Chronic alcohol ingestion causes changes in pancreatic fluid that create intraductal protein plugs that block small ductules. This results in progressive structural damage in the ducts and acinar tissue. Calcium complexes with the protein plugs, eventually resulting in destruction of pancreatic tissue. 4. Abdominal pain may be related in part to increased intraductal pressure secondary to continued pancreatic secretion, pancreatic inflammation, and abnormalities of pancreatic nerves. 5. Malabsorption of protein and fat occurs when the capacity for enzyme secretion is reduced by 90%. A minority of patients develop complications including pancreatic pseudocyst, abscess, and ascites or common bile duct obstruction leading to cholangitis or secondary biliary cirrhosis. We will now discuss the clinical presentation of chronic pancreatitis. 1. The main features are abdominal pain, malabsorption, weight loss, and diabetes. Jaundice occurs in about 10% of patients. 2. Patients typically report dull epigastric or abdominal pain that radiates to the back. It may be either consistent or episodic. The pain is deep-seated, positional, frequently nocturnal, and unresponsive to medication. Nausea and vomiting often accompany the pain. Severe attacks last from several days to weeks and may be aggravated by eating and relieved by abstinence from alcohol. 3. Steatorrhea, that is excessive loss of fat in the feces, and azoturia, that is excessive loss of protein in the feces, are seen in most patients. Steatorrhea is often associated with diarrhea and bloating. Weight loss may occur. 4. Pancreatic diabetes is usually a late manifestation that is commonly associated with pancreatic calcification. Neuropathy is sometimes seen. We will now discuss the diagnosis of chronic pancreatitis. 1. Most patients have a history of heavy ethanol use and attacks of recurrent upper abdominal pain. The classic triad of pancreatic calcification, steatorrhea, and diabetes usually confirms the diagnosis. 2. Serum amylase and lipase concentrations usually remain normal unless the pancreatic duct is blocked or a pseudocyst is present. 3. The white blood cell count, fluid balance, and electrolyte concentrations usually remain normal unless fluids and electrolytes are lost due to vomiting and diarrhea. 4. Malabsorption of fat can be detected by Sudan staining of the feces or a 72-hour quantitative measurement of fecal fat. 5. Surgical biopsy of pancreatic tissue through laparoscopy or laparotomy is the gold standard for confirming the diagnosis of chronic pancreatitis. 6. In the absence of histologic samples, imaging techniques are helpful in detecting calcification of the pancreas and other causes of pain, ductal obstruction secondary to stones, strictures, or pseudocysts, and in differentiating chronic pancreatitis from pancreatic cancer. Ultrasonography is the simplest and least expensive imaging technique, and abdominal CT is often used if the ultrasound examination is negative or unsatisfactory. 7. Endoscopic retrograde cholangiopancreatography is the most sensitive and specific diagnostic test, but it is reserved for patients in whom the diagnosis cannot be established by imaging techniques because of the potential for complications. We will now look at the desired outcome. The goals of treating uncomplicated chronic pancreatitis are control of chronic abdominal pain and correction of malabsorption and glucose intolerance. Let's now discuss pharmacologic treatment of chronic pancreatitis. 1. In patients with ethanol-induced chronic pancreatitis, abstinence is the most important factor in preventing abdominal pain in the early stages of the disease. 2. Small and frequent meals, that is 6 meals per day, and a diet restricted in fat, that is 50 to 75 grams per day, are recommended to minimize postprandial pancreatic secretion and pain. 3. Pain management should begin with non-narcotic analgesics such as acetaminophen or a non-steroidal anti-inflammatory drug administered on a scheduled basis before meals to prevent postprandial exacerbation of pain. If pain persists, The response to exogenous non-enteric coated pancreatic enzymes should be evaluated in patients with mild to moderate chronic pancreatitis. If these measures fail, consideration may be given to use of tramadol or addition of a low-dose opioid to the regimen, e.g., acetaminophen plus codeine. Parenteral opioids are reserved for patients with severe pain unresponsive to oral analgesics. In patients with pain that is difficult to manage, non-narcotic modulators of chronic pain, e.g., selective serotonin reuptake inhibitors, tricyclic antidepressants, may be considered. 4. Most patients with malabsorption require pancreatic enzyme supplementation, as shown in Figure 28.2. The combination of pancreatic enzymes, that is lipase, amylase, and protease, and a reduction in dietary fat, to less than 25 grams per meal, enhances nutritional status and reduces steatorrhea. An initial dose containing about 30,000 international units of lipase and 10,000 international units of trypsin should be given with each meal. 5. Oral pancreatic enzyme supplements are available as powders, uncoated or coated tablets, capsules, enteric-coated spheres and microspheres, or enteric-coated microtablets encased in a cellulose or gelatin capsule, as shown in Table 28.2. Micro-encapsulated enteric-coated products are not superior to recommended doses of conventional non-enteric-coated enzyme preparations. The quantity of active lipase delivered to the duodenum appears to be a more important determinant in pancreatic enzyme replacement therapy than the dosage form. Gastrointestinal side effects appear to be dose-related, but occur less frequently with enteric-coated products. 6. Concurrent use of an H2 receptor antagonist or proton pump inhibitor may improve the efficacy of pancreatic enzyme supplementation by both increasing pH and decreasing intragastric volume. Antacids have little or no added effect in reducing steatorrhea. Addition of an H2 receptor antagonist may be beneficial for symptomatic patients whose steatorrhea is not corrected by enzyme replacement therapy and reducing dietary fat. A proton pump inhibitor should be considered in patients who fail to benefit from an H2 receptor antagonist. Pause the video and carefully scrutinize Figure 28.2, which is an algorithm of guidelines for the treatment of pancreatic steatorrhea in chronic pancreatitis before advancing to the next slide. Pause the video and carefully scrutinize Table 28.2 summarizing enzyme content of selected pancreatic enzyme preparations before advancing to the next slide. Let's now look at surgery. The most common indication for surgery in chronic pancreatitis is abdominal pain refractory to medical therapy. Surgical procedures that alleviate pain include a subtotal pancreatectomy, decompression of the main pancreatic duct, or interruption of the splanchnic nerves. Finally, let's discuss evaluation of therapeutic outcomes. 1. The severity and frequency of abdominal pain should be assessed periodically to determine the efficacy of the analgesic regimen. 2. The effectiveness of pancreatic enzyme supplementation is measured by improvement in body weight and stool consistency or frequency. The 72-hour stool test for fecal fat may be used when the adequacy of treatment is in question. 3. Serum uric acid and folic acid concentrations should be monitored yearly in patients prone to hyperuricemia or folic acid deficiency. Blood glucose must be monitored carefully in diabetic patients. Thank you.